This is the case of 70 years old female. She has a lymphoma treated in 2009. She underwent to left pancreatectomy in 2013 for IPMN with adenocarcinoma. An MRI showed a new cystic lesion in the pancreas at the level of the resected area, and the patient is here today for US evaluation.
Here we are looking to this old lady with a history of resected IPMN in the previous some years ago, I think. And now we are going to look if there is any recurrence of the IPMN in the remnant pancreas. So I'm using the Slim scope, so a very easy to use, not that easy to stay stable into the duodenum, but the quality of the image is very nice. So I'm working together with Nick, he's here with me. Hello. And Assad as well. They are always quarreling about the orientation of my view, because as you know, I'm orienting the head of the patient on the left and the feet of the patient on the right. So,
which is the wrong way.
Which is the right one, but anyway,
I've tried.
I can show you poor guys also the standard standard orientation. Then, first of all, we start. I'm in the second part of the duodenum, so you see here the vessels, mesenteric vessels, and I gently turn the instrument to start looking to the pancreatic head. And so the first thing that I see here coming back gently is a duct. And you see here a duct coming from the dorsal part of the pancreas. So this is the dorsal duct coming down from the minor papilla, and I can easily follow the dorsal duct towards the neck of the pancreas. So this is the first duct that we usually are able to visualize when we look to this salt and pepper appearance of the dorsal part of the pancreas. Then I rotate the instrument anti-clockwise, and I'm finally look to the papilla area here above, to the ventral duct and to the common bile duct here. This is the very nice appearance of the ventral part of the pancreatic head. There are some slight changes, some spots, hyperechoic spots and something like that, that I don't know if Anand wants to comment about the possibility to have a diagnosis of chronic pancreatitis in this case. I don't know. But for sure in this area there are no big lesions, We have some collateral duct here from the dorsal duct, and also if we look to the ventral duct, probably we can see here going down, a collateral going down here, but not, and there's very small tiny cyst here, you see here, a very tiny cyst along this collateral duct of the ventral duct, and this is the common bile duct. So I can go back, and it's important to say that if you want to go back, particularly with this instrument, which is very floppy, you should go back always with the instrument in the straight position. So looking to the vessel, then you can turn again your instrument, and you can follow clearly here the dorsal duct going towards the neck of the pancreas. And I can see probably there are no big communication. And this is the ventral duct, you see? We can easily follow the ventral duct from the papilla down here, going towards the neck as well, and the common bile duct is above. I gently pull back the instrument, continuously following the ventral duct here, because I want to go to look for the neck of the pancreas here. You see that the gastroduodenal artery is coming here, so I'm approaching the neck of the pancreas. I gently pull back the instrument to follow the ventral duct, and you see that here is coming as a very small duct, dilated duct here. Okay, here we are, and we can measure that. So there is a dilation of the ventral duct, which is 9.8 millimeter long and 4.5 millimeter in size, that we can see, and we can clearly see the ventral duct going into this area. So probably is.
So you think that's the main pancreatic duct?
This is the ventral duct, and this is going here, and this is the starting of this cystic, the junction of this cyst. So it's a cyst that's starting directly from the pancreatic duct in the area of the resection, because this is the limit of the resection of the pancreas. You see that here there is no more pancreas. We are in the neck. This is the portal. This is the portal conference. This is the gastroduodenal artery. This is as you are used to look at. So this is the head of the pancreas. This is the neck with the gastroduodenal artery, the cyst, and the portal vein here. Okay.
Thank you.
These two lesions were not present last year on the MRCP. This appear.
Yeah.
This patient has developed a PT1 adenocarcinoma on IPMN of the main duct when she was operated.
So
I don't know. I don't know
the problem is.
how to manage to do a cytology here in this cyst, and I don't know.
I think that in this case, the patient, if you are going to show that is something that is going to change over time, as to perform a total pancreasectomy.
Yeah. Yes.
Pardon?
Wait and see.
Wait
I
and
would
see.
wait to see if it changes. It looks very.
Actually, it
no
looks
nodule,
very
nothing,
no
thin wall.
nodule.
But
no nodule.
also during the first, when I send this patient for surgery, there
There
is
were
no
no
nodule,
nodule.
there is nothing, there is just a dilatation of the main pancreatic duct in the tail, and this patient has a PT1 adenocarcinoma. It's for this reason that she developed again the same kind of lesion, and yes, maybe the solution is to reoperate the patient, but I don't know.
Do you have the idea of the surgical margins at the end?
It was free.
Was free.
Free, completely free. There is no IPMN on the margin.
What was the size of the T1 tumor operated?
I think it was less than 1 centimeter. It was 9 or 8 or 9 millimeters. Maybe just to follow, yes. And
You're not going to need it.
Okay.
It's too small.
okay,
We can. What about the audience?
yeah.
Which is your idea? Who is moderating?
There's Christophe.
Christophe. Okay, and
And
Anan.
Anan.
So guys, what?
Julio.
Julio. Okay.
How
and
many
Adrian.
people were
Okay.
here in the audience?
Yeah.
Paolo, there is a question in the audience.
Yes,
Just a
Yes.
second, please.
Please. Hello? Hello?
We can't hear you.
Probably post-surgical. This is the margin of the surgery.
Yeah.
It's just.
It's right
Okay,
above
okay.
it, yes.
Sorry.
The question was, there are T1 tumors below 10 millimeters which are metastasizing in the liver and other organs.
Wow.
So what would be the comment on that?
About IPMN, are we talking about IPMN lesion or adenocarcinoma?
No, the survival curve, the mean survival the curve at 5 years for the T1 lesion, which is less than 2 centimeter, is around 52%. This is on the surgical series. But of course, probably the half patient can die even with a T1 lesion, can die of liver metastasis. You know that the size of the lesion is this kind of cancer is very aggressive, and with the perinerval infiltration, this is quite why this cancer is very the prognosis is very poor.
But we also know more and more about the molecular testing in these kind of pancreatic tumors that they are not behave the same. I mean, it depends on the behavior of the molecular testing that we can even provide information regarding the expected survival. So I think it's quite tricky how to manage these kind of cases. And of course, if we decided to go for follow-up, it should be a very straight follow-up. But I think the option of surgery with the clinical history of the patient is not only a bad option. Maybe I will just have a discussion with the patient and take into account comorbidities, if the patient is already diabetic.
No, she has no comorbidities. But the problem is a total pancreatectomy. This is the comorbidities that we will induce.
Yes. This is the main problem. We have to be sure.
There's no neoplastic tissue.
No, we don't see no plan. But the first time also we don't.
You see from the stomach as well.
We
see
didn't
clearly
see
that from the stomach.
So the
You see-
surgical margin.
You see right on the
Marginal
around the surgical margins here. So it's
So this is the first exam she's having after the surgery? This is the new...
the first US.
the
Yes.
first US.
Because
She had
she
the
was followed
MRI.
by MRI. Because the MRI were normal, and the MRI of March found this cystic lesion, but the MRI of 2015 was strictly normal.
So it's a new lesion. So if it's a new lesion and you see the way you described, she presented with the first lesion, she's a young person. I think it may not be unreasonable to say, look,
Small lymph node.
we know
but
that's
it's
a very
close to
aggressive
the.
disease.
There's
Maybe
interestingly,
worse
there's a
with the
node here as
pancreatectomy.
well. Just it looks triangular and it's very.
Yes, with
there
the
is
hypercoagulin.
Okay, the decision is just to follow with a very close follow-up, maybe in 3 months.
Yeah.
I agree for this patient.